The liver is weeping fluid. Like it's just this wet fluid that's just like oozing out of the liver. And
I'm having like Beatles recollections here.
The weeping liver.
Oh, my guitar gently weeps.
Yeah, exactly. Okay, yeah, exactly.
Hey guys.
Hannah, Avi, how you guys doing?
We're back at it.
Coming into the fall. Okay, Tony, you have surprised us a little bit with this episode. You're going to kind of introduce the topic, so tell us, what do you have in store for us today?
Well, I want to talk capillaries, and hopefully after a little bit of introduction, this will become clear. But I want to remind the audience a little bit about the different flavors of capillaries, because at least I learned in med school that there are 3 different types. First, you've got your continuous capillaries. Those are the most common form. They're characterized by an uninterrupted endothelial lining that's joined by these tight junctions and supported by a complete basement membrane. And these are found in the skin, the lungs, the CNS, places where you don't really want things to be particularly leaky. All right, so that's capillary type number 1. Then you got the fenestrated capillaries. These have small pores, known as fenestrations, of course, within the endothelial cells, and that facilitates high exchange rates. So these fenestrated capillaries are found in organs where rapid filtration, secretion, or absorption occurs. So think of places like the glomeruli of the kidneys. And then finally, you've got the sinusoidal capillaries, also known as the discontinuous capillaries. They have large, irregular lumens and wide gaps between the endothelial cells with a discontinuous or even absent basement membrane. And so this allows for the passage of plasma, proteins, and cells and other large molecules between the blood and the surrounding tissue. And these sinusoidal capillaries are found in the spleen. Hannah, they are found in the bone marrow and in the adrenal medulla. But most importantly for this episode, they're found in the liver.
So we're kicking off with an anatomic review that was really a nice. That was a good flashback. And honestly, like I love that the ascending level of porousness of each capillary. It sounds like culminating in the sinusoidal capillaries. And so that was great. But there wasn't a question there. We always have a question, almost always. So what's your question?
Yeah, so I started with that as, I don't know, I guess a little bit of a lead into the question. So let me get to the questions. Think about those last types of capillaries, the sinusoidal capillaries, particularly of the liver. And they allow the free passage of proteins, including albumin. And if they do that, why do patients with cirrhosis and portal hypertension have high SAAG? So if you've got so little restriction to the flow of the proteins from the plasma into the ascites, shouldn't those fluids look very, very similar? And yet they don't. There is this difference as demonstrated by the SAAG. This I realized a few years ago, and it bothered me for the longest time. And I explored the answer, what I think is the answer behind it, and I wanted to share it here.
Amazing. Okay, so the question is, where does ascites come from, and why is the SAAG high in ascites from portal hypertension? Sort of. And maybe for the listeners, and because I am the person who was most recently the intern on internal medicine rounds.
Although that's been a while now.
Oh, it really has. But this podcast has been with us the whole way since I was a medical student being asked this question on internal medicine rounds. So maybe why don't we just take a stroll down memory lane and remind ourselves what the SAAG is? I will totally admit, this is something I always have to think through. It's not something that comes naturally to me. The SAAG stands for the serum ascites albumin gradient, and it is just simple subtraction, the difference between the serum and acidic fluid albumin concentrations. Just to, again, give some background to what you're saying. What is the albumin in the serum versus the albumin in the ascites? So a SAAG of greater than 1.1 grams per deciliter means that there's a bigger difference in the albumin concentration between those two fluids. which indicates ascites due to portal hypertension, most commonly cirrhosis. A SAAG of less than 1.1 grams per deciliter suggests non-portal hypertensive causes, for example, cancer or infection. And so, as you mentioned, Tony, the high SAAG in cirrhosis typically reflects low albumin ascites. But now that we've talked about SAAG, as I think about it, you're totally right. Why would this big, beautiful, very sinusoidal, very leaky capillary have such a big difference, be defined in its way by a big difference between the albumin concentrations? So how should we answer this question? Where do we go next?
Yeah. Before we go to where to go next, just another way to think about this is you'll often hear people say, "Oh, it's like transudative," right? That in the setting of portal hypertension and ascites, right? It's a transudative fluid. But transudative suggests that it's the water that's traversing, and what's kept behind is all these plasma proteins. But if you've got these super duper leaky sinusoids, the proteins are going into that same space. So there shouldn't be a difference between the albumin and protein concentration in the ascites and the albumin protein concentration in the plasma. And that's the question that was frustrating to me. So I feel like maybe the next place to go is to sort of discuss what sounds like a seemingly simple question. And it's, where does the ascites arise from, particularly in patients with cirrhosis and portal hypertension? And by where, I mean like where anatomically in the guts is it coming from? And I'm not sure, Avi, Hannah, if you've given this any thought or have a hypothesis, but like, from whence is it emerging?
Clearly not enough.
Share with you the incorrect mental model that I had until you shattered it.
Naive assumption.
Like 2 minutes ago by pointing out this fact that I should have noticed somewhere along the 10 years of medical training. Yeah, I always thought that like kind of like a Starling forces concept, that there's hypertension, there's greater pressure in some way further up, and therefore that increases an osmotic or hydrostatic pressure outward from the capillary somewhere slightly proximal or distal, somewhere a little bit prior to the portal vein. I'm realizing that might not be true.
Well, that's the thing, is like, which capillary bed? Where is the capillary bed? I don't know, Avi, what do you think?
I don't know. And this now probably makes no sense, but I assumed that the peritoneum was having some part of this too.
Right.
Just because it's like right there.
Exactly. So I spent actually quite a bit of time today trying to find a good picture of like cross sections of all different anatomic parts in the abdomen, and my mind was reeling, and I was like, this is why I'm not a surgeon. This is why I'm not a radiologist. But we'll still try to I'll still try to offer some explanation for where the ascites might be coming from. And what's interesting is, as you headed into the 1950s, so going back a number of decades, there was a lot of debate around this question of where is the ascites emerging from. And by ascites, I mean like, where is the fluid traversing from a capillary into the peritoneal space? And the prevailing theory at the time is kind of similar to what Hannah was alluding to. It was that the fluid was emerging as a transudate from the mesenteric or splanchnic vessels, particularly the capillaries within the mesentery. And that, I think, was holding a lot of sway at that time. And we could talk about like why that might have changed, but that's where people's minds were at.
I guess that sort of would make intuitive sense too, right? I mean, if and Hannah, I don't know if this is part of what you were thinking, but it does make sense if it's sort of upstream from where sort of like from this. It's like like a dammed river backing up, right? With this portal hypertension. And Tony, you'd mentioned we're dealing with continuous capillaries in these mesenteric vessels.
Right.
So it would make sense that you could have a transudate from that and the fluid would have a high SAAG. So it sounds like that's not the answer though.
I mean, it may be a partial answer, as we'll get to later, but I think the current feeling is it's not the main source of ascites in portal hypertension and cirrhosis. And investigators, authors, gastroenterologists, in the 1950s and 60s, they began to acknowledge that there were few clues that the mesenteric capillaries probably weren't the source. And the first was that if you experimentally ligate the portal vein, you don't typically see ascites. And even in clinical practice, I'm not sure if this is your experience, but portal vein thrombosis isn't a particularly common cause of large volume ascites. You certainly do get ascites, but not large volume, particularly if you compare it to hepatic vein or IVC clots, where you're much, much more likely to get large volume ascites, again, compared to the portal vein. So there's something about where the obstruction to blood flow and the increase in pressure is deriving that matters. And the classic hepatic vein thrombosis, Budd-Chiari syndrome, like that's, again, I would say, I think the numbers that I saw, like 80-90+% of those patients will have ascites, far higher number than in a portal vein thrombosis.
So it still sounds like a plumbing problem of some kind, but the question is sort of so it sounds like where the obstruction is, or the thing that's sort of causing higher pressures and resistance of flow that's causing it. And it sounds like if having clots sort of downstream from the liver, like in the hepatic veins or in the IVC, is going to lead to ascites, but having clots upstream in the portal vein, will lead to ascites, but having clots upstream in, say, the portal vein generally does not necessarily lead to ascites. So is this like a liver problem? I mean, this is a liver problem. We're talking about cirrhosis, but is this a liver problem?
It is. I mean, that's, I learned this, I think, for the first time on the Curbsiders podcast, where I was listening to an episode. I don't remember who the guest was, and forgive me, I should. But the way they described it is that essentially the liver is weeping fluid. Like it's just this wet fluid that's just like oozing out of the liver. And
I'm having like Beatles recollections here.
Like the weeping liver?
While my guitar gently weeps.
Yeah, exactly. Okay, yeah, exactly. I mean, while my liver gently weeps, I guess we could maybe name the episode that. And there are these really fascinating experiments where they would transect the diaphragm, push the liver up through the diaphragm, and then suture back the diaphragm off. And so now you'd have a liver sitting in the thorax. And then you experimentally obstruct the hepatic vein. And guess where the fluid forms? It forms in the thorax, like a pleural effusion, from this weeping liver where the fluid is just coming out of the liver, not in the mesentery where you still have those capillaries, those continuous capillaries. Now, does that prove that in cirrhosis ascites is derived from a weeping liver? No, but that and some of these other experiments really suggest that the issue is that the sinusoids have an increased pressure, and the fluid is moving from those liver sinusoids into this space of Dease, and then ultimately across the capsule and into the peritoneal space. These same sinusoids that are very, very leaky.
You really made all of that evidence come together. I think, there you go.
Right now.
No, but I mean, I do think that fits with other conditions that cause kind of pre-sinusoidal hypertension that are less likely to cause significant ascites, like portal vein thrombosis. I think that's a really instructive example. I'm wondering, schistosomiasis is sort of another example. I don't have a high enough clinical end to have a good sense of how much ascites is involved.
Yes, schistosomiasis actually is, to my mind, a perfect example because if you look worldwide, it's one of the most common, in some sources, the most common cause of portal hypertension. And splenomegaly and varices are very, very common in patients with schistosomiasis and portal hypertension. But ascites, particularly large volume ascites, is rare. And that's because the portal hypertension is pre-sinusoidal. In schistosomiasis, the liver sinusoids themselves don't see that pressure, and because that pressure is not elevated there, you're not getting the movement of fluid again into the space of Dease across the capsule and into the peritoneal space in the same way that you are with cirrhosis, hepatic vein thrombosis, and things like that.
Tony, one question for you that comes to mind. We've talked a lot on this show previously about hepatic hydrothoraces that, and I know you've talked about why they're usually right-sided. I don't recall that we talked about that if the liver is weeping and making the ascites, like, do you think that could be part of the reason that it's often on the right?
I have thought that same question, and I think it's a perfect question. Like if the liver is crying and like jabbing itself up into the diaphragm, like wouldn't it make sense that the fluid just would go across the diaphragm, as opposed to if the source were the mesenteric vessels, then a right-sided or left-sided hepatic hydrothorax, those should be equally probable. I haven't been able to find any sources that suggest that as a hypothesis, but I think it makes sense. And so, like, why not?
It also comes back to the endometriosis sidedness question that I think we investigated way early on.
Yeah, and so so the
like
counterclockwise,
yeah,
the counterclockwise fluid flow, but you sort of wouldn't need to invoke that here if
it's coming straight.
If it's just like coming out of the liver right under the right hemidiaphragm.
Exactly.
Just a question there in the thought. But well, so let's come back to high SAAG and cirrhosis. So with the serum ascites albumin gradient, if the source of the ascites is these, or if the sources of the ascites are these sinusoidal capillaries in the liver, we still haven't explained the gradient though, the higher gradient, because like, you know, again, why is the albumin content of ascites so much lower than the albumin levels that are in blood if these are very porous vessels?
Right. And there's almost certainly a number of different explanations, and I'll focus on one and then maybe come to another. And the most important one, the one that I think I see most commonly in literature on this, is a process known as capillarization or capillarization. We'll go with capillarization because I'm not exactly sure how to pronounce it, but we'll go with that.
Sounds good. It sounds better that way. The first way, it sounds good. But what does it mean? Just to clarify, like, is the liver turning into one large capillary or becoming more capillarized?
Yeah, so kind of, not quite, maybe. So what is happening in capillarization in cirrhosis is the transformation of these leaky hepatic sinusoids into capillaries that are more continuous, like the sort of tighter ones that we mentioned at the top of the episodes. So you have sort of more basement membrane, loss of these like fenestrae, and sort of a tighter, again, capillary space. And in some ways, it's almost as though the capillaries within the liver, these sinusoids, turn into those that are found in the skin, the lungs, and the CNS, the ones that are, again, very, very restrictive. And this process has been identified as early as 1963 by Fenton Schaffner and Hans Popper. So we've known about it for a while. In subsequent decades, we've learned that it's driven by the chronic inflammation that you see in cirrhosis. And that activates these hepatic stellate cells, and they deposit extracellular matrix in that space of Dease, that area just outside of the sinusoids and between the sinusoids and the hepatocytes. But this resulting capillarized capillary, this capillarized sinusoid, that impedes the exchange of proteins, particularly albumin. And so as cirrhosis progresses and capillarization worsens, the hepatic leaky sinusoids kind of turn into continuous capillaries.
That's so fascinating. I mean, is SAAG like a biomarker of cirrhosis severity? Like, at least on the sort of pathologic level, right? Like, does the SAAG go up as cirrhosis progresses?
You know, then I have searched every tool possible to try to find a study that's looked at this exact question, and I cannot find one. But I have found studies that suggest that the answer to your question, Avi, is yes. So I'll give an example. So there was this 1968 study led by Charles Witt and William Cole. And so what they did is they examined the protein content of ascites as cirrhosis worsened. And they found that the protein concentration of ascites, and they expressed it as a percentage of plasma, that as cirrhosis progressed, that percentage went down, meaning less protein was in the ascites as compared to in the plasma. They didn't calculate SAGs back then, and so they didn't offer that in the paper, but I think it's a pretty close comparator, and it does suggest that as the liver fibrosis progressed, there was increased restriction of protein movement from the liver capillaries into the peritoneal space, And probably had they done it, we would have seen an increase in SAAG, though, again, I don't have that study to actually show you.
And so when someone gets a TIPS, I mean, are we just thinking on much more of a kind of macroscopic level than this microscopic idea of extracellular matrix and the fibrosis happening and the capillary change happening? Is it just that we're shunting the fluid away from that liver, those liver capillaries, or kind of almost neocapillaries that are then going to leak fluid?
Yeah, I mean, TIPS probably works in a few different ways. One is it certainly relieves the portal hypertension. So if there is a contribution from the mesenteric capillaries, it's going to reduce that. And the other is that it probably reduces, because of decreased inflow to the liver, probably decreases portal pressures within those sinusoids, also reducing ascites formation. So the TIPS probably gets at a couple of these different mechanisms.
Yeah. And so do the mesenteric capillaries that I and Avi had, I think, been imagining were the source for a long time?
I was like totally off. I don't think I was even in the right circulatory.
Outside of that context, or do people think that they come into play?
Yeah, they probably do. There's this one author, Andres Cardenas, who, when he wrote one of the best papers, was actually at BI, where Avi and I trained, although I don't remember ever seeing him in the hallway. So he's argued this in a few different papers, as have a few others. And what they put forward is this idea that the acidic fluid in cirrhosis derives probably from both the hepatic sinusoids and mesenteric capillaries, particularly as cirrhosis worsens. And so in patients with high protein concentration in the ascites, it's probably true that the predominant site is the liver, for the reasons that we've described, right? You leaky capillaries, leaky sinusoids, you're going to get a high protein ascites. But as liver cirrhosis progresses and portal hypertension becomes more severe, the protein concentration of the ascites fluid decreases. I mentioned that from the study from the 1960s. And so Cardenas and others argue that the increased capillarization of the sinusoids play a role, but it's also probably true that at some point the mesenteric vessels, the mesenteric continuous capillaries, also contribute to some extent.
And is there some thought about why that changes over the course of disease?
I think the belief is that as the cirrhosis worsens and you have increased splanchnic arterial vasodilation, that leads to increased blood flow to these continuous capillary beds. And at some point, the hydrostatic pressure in those capillary beds gets high enough that even those areas begin to weep some fluid. And so you got the weeping liver and then maybe the weeping bowel capillaries. And this combination, particularly if the liver sinusoids have undergone capillarization, is going to give you your classic high SAAG ascites, where the protein content of the ascites is probably pretty low.
Interesting. Okay, so there is eventually maybe some hydrostatic component theorized.
So yeah, so I think the way to think about it is that you guys were definitely right.
Just kidding.
And wrong.
I was not right. Let me just say that.
But I can't believe I never thought, I mean, what a great question. I cannot believe that this is, we've all had so many hours sometimes kind of thought while rounding. And this has never come up.
Yeah, I mean, the idea that cirrhosis leads to a transudative ascites, well, like, it's so leaky, a whole red blood cell can go through it. Like, there's no transudate across a liver sinusoid.
I want to know is how we've got a whole episode about this, talking about SAAG stuff, and we haven't made a Screen Actors Guild award.
We just did.
We're more into paperback writers. Right. Tony, do you have any takeaways for us?
I sure do. So first, in a non-cirrhotic liver, that liver contains the leakiest of all capillaries. That these are the ones known as the sinusoidal capillaries. But despite these leaky sinusoidal capillaries, the ascites of cirrhosis actually has a low albumin content. The main reason for this, I believe, is the capillarization of the sinusoidal capillaries, where fibrosis ultimately turns them into more of a continuous capillary, restricting the movement of plasma proteins. But, Hannah, you will feel reassured that as cirrhosis progresses, the mesenteries continuous capillaries also probably play a role to the high SAAG ascites.
Well, that wraps up another episode of The Curious Clinicians. Thank you, as always, for joining us. Claire Morgan of notearly.com is our audio editor, and Giancarlo Bonomo and Millennium Mana are producers for the show. You can join our mailing list at curiousclinicians.com to stay up to date on episode releases and have detailed notes delivered directly to your inbox. You can subscribe to our Substack at thecuriousclinicians.substack.com. Physicians and other healthcare professionals can earn CME and MOC credits from VCU Health just for listening to this episode. For more information, visit ce.vcuhealth.org/curiousclinicians. And as always, the information contained in this episode is for educational and entertainment purposes only and does not constitute medical advice. Until next time, we've been the Curious Clinicians.